You know that the central nervous system has a huge requirement for oxygen. Again, taking up 25% of your cardiac output. So very metabolically active system for no more weight than it is. Unlike the rest of the body that can use fatty acids and anaerobic glycolysis for energy, your CNS can't, nervous system can't. It can only use glucose. And as I mentioned before, though, you don't need insulin to get glucose into a neuron. It goes in there, it freely flows in there. One of the problems about the CNS, though, is, you'll see later on, is that these neurons, they have an enormous number of receptors, not just at the synaptic clefts, but on the neurons themselves, on the dendrites. I mean, it's an enormous number of receptors. As a matter of fact, there are more estrogen receptors in your brain, specifically the hypothalamus, than there are anywhere else in your body. And that's pretty impressive. And I'll go into that when we start talking about the neuroendocrine control of behavior next week. But because of that huge number of receptors, it's also a target for viruses and chemicals that can bind to it. And you know there are several viruses that can cross the blood-brain barrier. The ependymal cells that I mentioned earlier, they're responsible for the blood-brain barrier. Well, let me back up. They're responsible for the barrier between the CSF and the brain. This is not the blood-brain barrier. The blood-brain barrier is formed because the blood vessels are not fenestrated. There are no holes in the blood vessels. So you have two types of barrier. One is between the CSF and the brain. The other is between the blood and the brain. Viruses and chemicals, though, are able to breach one or both of those barriers, and we'll cover some of those viruses later on. Okay, so when you're talking about lesions of the nervous system, there are several factors that you have to keep in mind. One is the size of the lesion. You can have a lesion, a tumor, in the anterior fossa of the skull here, the size of a tennis ball, and you don't even know it. Or let's go with a ping pong ball. That's a little bit more realistic, unless you got a really big head. But we'll go with a ping pong ball, and you don't even know it. The location of the lesion, though, is also important. You can have a similar type of problem, a tumor of the same cell, in a place like the midbrain or the brainstem, and it could kill you. So location, 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 that real estate is important. The other thing that's important is momentum, how fast that thing grows. There are certain tumors of the central nervous system that grow very slowly. A meningioma, a tumor of the meninges, grows very slowly. A glioma, which is a tumor of glia. It's actually called a glioblastoma. There are different stages of glioblastoma from 1 to 4. 1 grows slowly. You may live your entire life with this tumor in your brain. It just sits there and grows so slowly. Class 4, though, you're dead within 6 months. So momentum of growth is definitely important. Dr. Veneta, his daughter-in-law just died of a glioblastoma just last month. She was diagnosed about a year ago, and it didn't take long. All right, so what happens when you get an injury to the nervous system? And we'll go over several different types of injury and what the response is. One thing is that when you look at the blood supply of the nervous system, or the central nervous system, if this is the brain right here, for example, and I have a stroke, a blood clot, for example, right here. So this area is fed by one artery. So if that artery is blocked, that tissue will die. Hands down, that tissue will die. But this artery also supplies the area around it, as do other arteries. So this is your primary infarct area. This area around it, you might lose a little bit of it, but not all of it. That's your secondary infarct area. What you want to do in treating stroke, for example, is to minimize the secondary area. Now, a lot of times during a stroke, and we'll talk about strokes in detail later on, but a lot of times the blood pressure will be elevated. Huge elevations, blood pressure. One of the things in stroke treatment is to consider how far and how fast you need to drop that blood pressure. If you lower the blood pressure, you're going to lower the perfusion of this secondary area. We don't really want to do that. We want the blood pressure up so that the secondary area remains perfused. And there are guidelines on how much to lower the blood pressure and when to lower blood pressure and what to use. This is a little bit high, but if a person came in with a blood pressure of 180 over 100, you wouldn't even treat that. You want this area perfused. The second thing here is that when you start killing neurons, they dump their neurotransmitters. The predominant neurons of the cortex are excitatory. If all of a sudden you have an area of deadness with leakage of these excitatory neurotransmitters all out into the milieu there, what are they going to do? They're going to excite all of these other neurons. The constant excitation will kill them over time. And that's what this excitotoxicity is. You're trying to limit the degree of excitotoxicity and the ischemia in injury.
Are the branches of the arteries, are they short enough that you can't get like a huge infarcted area? Because usually when you have an infarct, they're pretty small, right?
Well, we'll cover that.
Okay.
And then you can infarct the entire middle cerebral artery that'll wipe out the entire, that part of your brain. Most of the time, though, you're going to block a branch of the middle cerebral.
Okay.
And so we'll go over that later on. Okay, so one of the things that happens with injury to the brain is edema. Edema can come from several different sources. It can come from infection of the brain, causing edema, just like an infection of the skin. It can come from trauma. If if you're in a car wreck or something, and your head hits the dash, that trauma can produce edema. There are a couple of examples here that I didn't really hit my head on the I did this. Okay? All right. So, in people with hyperosmolar, non-ketotic hyperglycemia, type 2 diabetic, with a blood sugar of 700, they're going to have mental status changes. They come, because they have Karo syrup circulating, they come into the emergency room or to the clinic. I don't know how many patients I've had come into the clinic. You get a glucose, figures their blood sugar on them, and it's over, you know, like we saw on Friday, it's too high for the meters to read, over 600. You don't even know what it is. Well, you're having mental status changes. The last thing you want to do is drop your blood sugar too fast. No more, this is the rule of the day, no more than 100 milligrams per deciliter an hour. Otherwise, all that glucose coming out of the circulation will cause fluid to, a fluid shift in the brain, and you wind up with edema, cerebral edema, and you can die. Also, if you're an alcoholic and you drink your dinner, or you drink all of your meals, over time you're going to be vitamin B12 deficient. And thiamine, actually this is thiamine, not B12. It should read thiamine. If you're thiamine deficient, if you come into the emergency room and you're comatose, and I give you glucose, and your thiamine level is too low, your brain swells, and you can kill somebody doing that. So you never give glucose in the emergency room to a comatose person without also giving them at the same time an injection of thiamine, an IM injection of thiamine. It's very quick. Increased intracranial pressure can come from several different mechanisms. When you do a lumbar puncture, a spinal tap, when you put that needle in, the needle has a stopcock on it, right? So when you put it in, CSF doesn't pour all over the place. You put it in, and you open the stopcock, and you get a little bit of CSF back to know that you're in the right place. Then what you do is you have a tube, a graduated cylinder here, you put on the stopcock, and then open it up, and the CSF, the pressure inside the CSF, will go up in that tube. That's the opening pressure. Normally it's between 10 and 25 centimeters of CSF. It's not millimeters of mercury, it's of CSF. An increase in intracranial pressure can increase the CSF beyond 25 for various reasons. One is you make too much CSF. Two, you don't get enough CSF removed back into the venous circulation. Due to obstruction, for example, of the ventricular system, from a tumor, from a hematoma, whatever. Or if you have bleeding into the subarachnoid space, when you open that thing up, I mean, you wind up getting blood. I mean, not blood, but the CSF will be contaminated with blood from a bleed. These people will present with ICP, with headache, nuchal rigidity, meaning, you remember this is the ligamentum nuchae right here? They don't want to move their neck. And if it's too much, mental status changes. And you remember the ophthalmic nerve is is a projection of the CNS, of the brain. It's a tract of the brain. The ophthalmic nerve is surrounded, if you remember from anatomy, is surrounded by meninges. If I have an increase in pressure in the CSF, it's going to project onto the termination of the ophthalmic nerve, which is the optic disc in the retina. You can wind up with papilledema, which looks like this. There's the opening of the optic nerve into the retina. So there are three features. One is the margins are blurred. Two, it looks like it's bulging at you, because it is. And three, because it's bulging at you, so if this is the normal retina, and you've got the normal optic nerve is that, and now it's like that because of pressure behind it, the arteries that are coming through the optic nerve, the branches of the ophthalmic artery, have to step off of that protrusion. And that's why they look like they're stepping off instead of a straight shot. They're having to step off of the papilledema. Have I got that? There are different types of herniation symptoms based on ICP. You can herniate through the falx cerebri, which is right here. There's the falx cerebri. You can herniate one side into the other. Remember, the falx cerebri has a free margin. This thing right here is called the corpus callosum. That bridge between right and left hemispheres called the corpus callosum. Sitting on top of the corpus callosum is the anterior spinal arteries. Remember anterior cerebral arteries. Remember they come out and go up and over in between, right? So if you have a herniation, you can compress that anterior cerebral artery, which supplies the medial part of the brain, or the cortex. And we're going to talk about this later on, but I can tell you right now that the medial part of the cortex, right here, right in the middle, controls from your knees down. You can't move your feet on one side. You have no sensation in your calf and foot on one side. That's one type of herniation. Another type of herniation is a tentoral herniation that you see here. Transtentoral, sorry. So you've got the tentorium cerebelli that sits over the posterior fossa. You have pressure up here, so there's the tentorium cerebelli. You have pressure up here, it's pushing down into the opening of the tentorium cerebelli, which is where the brainstem is. There's the brainstem. You don't want to go pressing on the brainstem. This part of the brainstem we'll cover next week. It's called the mesencephalon. Two of the nerves that come out of the mesencephalon are cranial nerves 3 and 4. Roman numeral 3 and 4. They control your extraocular eye movement muscles. These people present not only with headache, mental confusion, and everything else, but with paralysis of their ability to rotate their eyes. This is why you test the extraocular eye movement muscles. One of the thousands of reasons you do this. And the last type of herniation is a tonsillar herniation. The tonsils are an area of the cerebellum, so this is cerebellar tonsils. They herniate through the foramen magnum. The foramen magnum is the junction between the spinal cord and the medulla. In the medulla, you have these centers that control the respiratory function and cardiac function. do not want to go putting pressure on those structures, because you have a tendency to go into arrest. So you have vault herniations, transtentorial, or tonsillar herniations. Okay? Ventricles of the brain. You make about 150 cc's of central cerebrospinal fluid every day. It's made in the ventricles of the brain. You have two lateral ventricles designated 1 and 2, but one is not the right or the left. They just numbered 1 in Roman numeral 1 and 2. So people just call them lateral ventricles. The lateral ventricles drain into the third ventricle through a foramen. The third ventricle is a midline structure. The third ventricle drains in through a tiny channel in the brainstem called the cerebral aqueduct. The particular part of the brainstem is called the mesencephalon. You'll see this next week. The third ventricle drains into the fourth ventricle. And in each of these ventricles, there's a substance called choroid plexus. Choroid plexus is the stuff that makes the CSF, synthesizes it. The CSF escapes the ventricles through 3 holes in the fourth ventricle. You see these 2 holes right here laterally? They're called the foramina of Luschka. And there's a midline hole called the foramen of Magendie. I ain't making it up. It's like Magendie, M-A-G-E-N-D-I-E. That's the midline hole. You don't see it in this slide here. These are the 2 lateral ones, and then the midline one. That's how CSF gets out of the ventricles and will bathe the brain or the CNS. Now I'm going to show you those 3 holes next week when we do the anatomy of the brainstem, which I think is on Tuesday. CSF also circulates down through the central canal of the spinal cord. So when you look at pictures of the spinal cord, you recall that there's a little hole in the middle. That tiny little hole contains CSF. It becomes relevant in a disorder called the name of the disorder, don't get freaked out, it's called syringomyelia. I'm going to say it again when we talk about spinal cord, so don't even write it down now. Okay? But that central canal containing CSF is not to be discounted. Okay? For that one reason.
When
Yeah.
you have like a brain injury and you can see CSF coming out with the ears, what hole or what is that going through?
So I'm going to talk about that actually. If you were to look at this right here, if you had a basilar skull fracture, you get CSF leakage out of the, you get CSF leakage out through here. You remember when you took out the brain, when you took, we took out a couple of brains. Didn't we? Yeah. We took out the brain, in the floor of the cerebral vault, the meninges were still in there, right? So if I'm holding the brain, remember the pia is the outermost covering of the brain, but the arachnoid came out with the brain, right? So what we were looking at was dura, on the floor of the cranial vault. If we fracture that bone, you know, one of those bones, the temporal bone, the occipital bone, sphenoid bone, whatever, you know, rupture that dura and the arachnoid that overlies it, CSF can pour out your nose, it can pour out your ear, it can fill up your middle ear. Anytime in trauma you have clear fluid draining from somewhere up here, that's a bad sign. Okay? All right. Hydrocephalus is a condition where the pressure inside the ventricles goes up because it can't drain properly. The most common place to block the ventricle drainage is right here in the mesencephalon, which is right about there, at the cerebral aqueduct. You see, if I put a little tumor right there, I could block the whole third and lateral ventricles. If I put a tumor up here, I could block one lateral ventricle. It's going to keep producing CSF, and it's going to keep expanding that ventricle. That's hydrocephalus. A glioma here in the mesencephalon blocking the cerebral aqueduct is a nasty tumor for several reasons. One is it's non-operable. You can't get to it. You can't go take it out. And two, you're going to have a shunt to shunt the CSF away from the ventricles. So they'll go in here and put a shunt into the third ventricle and run it, snake it sub-Q all the way down to your abdomen or sometimes in your chest, and then you'll be draining CSF into your abdomen, into your peritoneal cavity where it's reabsorbed. Shunts are very common. People who have spina bifida, you remember spina bifida from? They always have a shunt because the CSF flow is not normal. They will always have a shunt. Look in their neck. You'll see like a little thing that's about the size of a vas deferens running right here in their neck. You'll see it. The reason I say that is because it's hard like a vas deferens. It feels, if you felt the shunt, it's not a rubbery tube. It's a hard tube. Feels like a vas deferens. All right. There's an example of hydrocephalus here. You got to shunt the CSF off. If hydrocephalus occurs before the flat bones of your skull have fused, then your skull will increase in size. Your neurocranium will increase in size. That's what this bullet point is saying here. Back when I was growing up, before treatment, I mean, nobody has this occurring now because it's recognized and treated with a shunt. Nobody, no kid has this now. But when I was in school, there was no way to diagnose this early, and you would have these kids with these big heads. And the CSF inside the ventricles expands, destroying the neural tissue. They were always mentally challenged pretty significantly. So you'd have, I remember my mom was an RN in a place like a children's center, like over in Bethany, where they had these kids, or they very developmental problem kids, not psychological. I mean structural problems with CNS. But they would have these large-headed kids who were retarded. That's when I was growing up, and they were called waterhead babies, because of the amount of water or CSF in the ventricles. I mean, thankfully, you never see that anymore, but if you Google waterhead baby, You'll see that. Okay? There's another type of hydrocephalus here. It's called normal pressure hydrocephalus. It's kind of a misnomer. What this is it happens most often in the older population, geriatric population, and you have a decrease in the reabsorption of CSF. So very slowly, over an extended period of time, your ventricles get larger, 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 larger. By displacing or damaging the neural tissue, they wind up with dementia. I'll talk about the difference between delirium and dementia here a little bit, but they wind up with dementia. Alzheimer's-like symptoms. Because it puts so much pressure on the motor functions of the brain, they have gait disturbances, and finally they lose, not finally, at the same time, they lose they have urinary incontinence. Not bowel, urinary. So those three are hallmarks of normal pressure hydrocephalus, which is often confused with the diagnosis of Alzheimer's or advanced Parkinson's disease. That sounds like a board question. That really sounds like a board question. How do you distinguish normal pressure hydrocephalus from Parkinson's disease versus Alzheimer's? What is the pathophysiology of those three? That type of stuff, they eat that up on the boards. Okay? And we'll go over Parkinson's versus Alzheimer's later on. Alzheimer's, however you pronounce it. Traumatic injury. Getting a skull fracture is just not a good thing. If the skull fracture is very small and doesn't produce any intracranial bleeding or focal neurologic signs, then you can just sit on it and watch it. However, if it's like these guys, where you have a depressed skull fracture, and this is something you always want to note in your, when you're doing a trauma survey, somebody comes in to the ER, you want to definitely reach up here and grab their skull and make sure you don't have any type of depressed skull fractures, okay? And because there may be a depressed, you don't go poking in the head, or you might cause greater problems, okay? Here's another one that probably can just be watched. However, you'll notice that the intracerebral bleed associated with it, this is something that's going to have to require work. If I told you that this section, right, so you got to think about it here for a minute. What do you think is the cause of that?
Blood trauma.
No, I mean, the rupture of what vesicle? What vessel is causing that?
Middle meningeal.
The what?
Middle meningeal.
Middle meningeal. Look how big this skull is here. So that means the CT slice is not through the top of the skull, it's through the middle of your skull. That's the temporal bone. There's the frontal sinus. That's the temporal bone. What vessel runs up the temporal bone? The middle meningeal. This is an epidural hematoma. What happened though was when I took that baseball bat and hit her, now this, you look at a CT as if you're standing at the patient's feet looking up towards their head. So this is the patient's left side right here. If I hit her in the left side of her skull and cracked her skull with that baseball bat, the force transmitted through her closed head, and she wound up with contusion or problems on the other side. Remember from anatomy, this is coup contra coup. This is an example of a coup contra coup lesion. That's damaged only because of the transmission of force. This is the direct blow that produced that skull fracture. This one up here in the middle is rather it's small, not depressed. You can probably just sit on that one because there's no intracranial problem going on. This is a plain film over here. That's what a skull fracture looks like on a plain film. You see that linear line? They are very difficult to distinguish, and I've sat there many a night pondering, is that a skull fracture or is that the normal suture line on a plain film? That's why you know, to rule out skull fracture, you gotta get a CT. Versus concussions, where you don't produce identifiable damage in the cranial vault. What happens is more or less a local injury, and it's transient. Usually within minutes to hours, you're back to full function. Of course, if you get this over and over and over again, especially in the boxing world, it has its own designation as dementia pugilistica, from getting hit in the head so many times. And of course, all the new information coming out in the movie Concussion. Who was that? Will Smith? Is that who was in that movie?
Yeah.
Will Smith? With the NFL. And there are identifiable changes in microscopic changes in the nervous system of these players who get chronic head injuries. There is a concussion protocol that if you're working the sidelines of a football game or any sports event, high school, college, pro even, that if there is a blow to the head and there's a little bit of, get your bell rung, you have to go through these different steps in order to be reinstated. So you probably will not be able to go out that same game, and over a period of days, you'll have to pass this protocol in order to get back in the game. And a lot of it has to do with mental acuity. Any questions about concussion? It's a big deal these days. Versus traumatic injury producing a contusion. A contusion is an actual anatomical damage to the brain that you can see. The one that's most unfortunate is all too frequent in Oklahoma, and that's the shaken baby syndrome. Where you take an infant, less than a year old, shake them and their head goes back and forth and their brain winds up banging against the frontal and occipital bones, producing damage in those two areas. It's, there was, you remember Kelsey, was it Kelsey Briggs, the little 5-year-old that the courts, it was in the paper this morning, the courts have said that the grandparents can sue DHS for neglect. So, anyway, that was in the paper today. Any questions about the distinction between concussion and contusions? Contusions are actual physical changes. You can see it. There's bruising of the brain. A concussion, it's not. Let me see, I think we might have to stop here. Yeah, let's stop here before getting too far into this, okay? Any questions about anything I've talked about? All right, all good. We'll enjoy you tomorrow. And, see you next week.